The purpose of this video is to present a systematic approach to laparoscopic suturing based on geometric principles and to highlight visual cues that experienced surgeons utilize to aid in depth perception. The main obstacle in learning to suture laparoscopically is overcoming the perception of a three-dimensional operative field presented on a two-dimensional monitor. The ability to perceive depth is difficult due to the monocular vision that is created from viewing a two-dimensional monitor. There are two categories of monocular cues, those of size and motion, which lead to a surgeon's ability to perceive depth. Visual angle is the most important factor in one's ability to perceive depth. In art, this is referred to as perspective. Here are examples of how the visual angle changes our ability to perceive depth in laparoscopy. When the surgeon is familiar with the size of an object from previous experience, information about depth can be inferred. When two objects' relative sizes are known, information about the relative depth of these two objects can be determined. Monocular cues from motion are vital to establishing depth perception in laparoscopic surgery, and may be from the motion of the object, observer, or from occlusion. Kinetic depth perception is determined by dynamically changing an object's position relative to a fixed observational point. If an object or plane is rotated, the visual angle is altered. These movements allow the observer to calculate depth. Motion parallax occurs when the observer changes their perspective in relation to a stationary object. Occlusion results when one object blocks another object, which allows the surgeons to rank objects in their order of depth. Occlusion cues can aid or impede a surgeon's ability to efficiently grasp objects. The rotation of the instrument tip alters the visual angle created between the laparoscope and the jaw of the instrument. The optimal visual angle occurs when the tip of the instrument is rotated at a 45-degree angle relative to the laparoscope, because this allows the most information about depth to be inferred. In this section, we will discuss the geometric principles of parallel planes, perpendicular planes, and the concept of triangulation. By definition, parallel lines and planes do not intersect or meet. Lines and planes are considered perpendicular if they intersect at congruent 90-degree angles. The closer an object and instrument are to a perpendicular angle, the more likely it is that the object can be grasped. The more the object approaches a parallel angle in relation to the instrument, the more likely they will not intersect and the object will be missed. When two ports are placed, a plane between these ports is created. The relationship of this plane in relation to the laparoscope is referred to as triangulation. Here you see how the planes created by these port placements correspond to the laparoscope and the resulting triangulation for each configuration. Ideal triangulation occurs when two instruments are perpendicular to one another with the camera positioned in between. However, this can be difficult to reproduce in pelvic surgery due to the poor ergonomics created by a contralateral port placement. To overcome the poor ergonomics, many gynecologists have adopted a port configuration with a suprapubic port or an ipsilateral port placement. Here we will present a systematic approach to suturing that utilizes the geometric and visualization principles previously discussed. This systematic approach can be applied to all port configurations, contralateral, ipsilateral, and suprapubic, with the goal to improve surgical efficiency. We have divided laparoscopic suturing into three main sections to help aid in conceptualization and for training purposes, which are setting of the needle, tissue reapproximation, and knot tying. The goal is to set the needle in a plane that is perpendicular to the rotational axis and shaft of the needle driver. For explanation purposes, we have three named points, A, B, and C. The needle is introduced with the needle driver at point A. Next, drag the needle until the assistant grasper is perpendicular to point B. The needle is righted by moving the suture with the needle driver. The needle is grasped at point C. By rotating the needle, a perpendicular relationship can be confirmed. These steps can be followed regardless of the port configuration, as long as the surgeon understands how the port placement alters the relationship between the camera, needle driver, and needle, and how this alters the perception of the operative field. Many surgeons use an alternative method to set the needle, where the needle is introduced with the assisting grasper at point A. The needle is then positioned and grasped by the needle driver at point C. The assisting instrument then manipulates the suture until the needle is righted. Once the needle has been set, it can be passed through the tissue. The steps of this section are tissue preparation, driving of the needle, and rotation. First, the assisting grasper is used to place the tissue in a parallel plane to the shaft of the needle driver. This allows the needle to be passed perpendicularly through the tissue with an axial rotation of the needle driver. The needle is rotated through the tissue until the assistant grasper is perpendicular to the curve of the needle. The needle is grasped at point B, rotated through the tissue. The alteration of the tissue plane's visual angle by motion aids in determining the entrance and exit points of the needle through the tissue. If bridging of the tissue is to be performed, the tissue is placed into position and the needle is grasped and passed through one side of the defect. The other side of the defect is grasped and placed in a position that enables passage of the needle through the opposite side. The rotation of the needle is continued. We have divided the knot tying process into 3 steps, which are preparation of the loop, throwing of the knot, and securing the knot. Loop preparation is the most crucial step in intracorporeal knot tying and consists of 3 elements, which are positioning suture parallel, preparation of a short tail, and formation of the loop. Once the needle is rotated through the tissue, the suture is pulled until the suture exiting the swedge of the needle is parallel to the shaft of the needle driver. A short tail of about 2 centimeters is then prepared. To form the loop, the assisting grasper is moved across and over the suture line. Now the knot is ready to be thrown. To throw the knot, a clockwise rotation is made around the parallel suture, and then another rotation is performed to create a surgeon's knot. The short tail of the suture is then grasped. To secure the knot, the loop is moved away from the knot. The tail is then moved over the suture line, and the assisting grasper is moved in the opposite direction until the knot is secure. The knot preparation phase begins again, and the second loop is formed, moving the assisting grasper across and over the suture line. A counterclockwise throw is made, and the short tail is grasped, the loop moved away, and the tail moved over the suture line to secure the knot. Proficient laparoscopic suturing requires an understanding of how the plane of the port configuration corresponds with the visual angle of triangulation and how to systematically manipulate the suture and tissue to perform the desired task.